Today's my topic is a very relevant topic, that is the pitfalls in diagnosis and phenotypic difference related to skin color. So what is color of skin? Who are the color of skin? The color of skin, in a word I can say, the person other than Caucasian, all belongs to this group. So there is a huge number of people in this group. And what are the causes of the skin color distribution? We have heard in previous lecture, genetic is one of the important. Environmental skin exposure is also important. That is, sun exposure has a significant effect on color of skin. Other than some historical factors are there, the mass migration, population mixing, some historical event like colonization and slave trades before. All this causes the different color distribution in this globe. So we can see the skin pigmentation diversity. Usually it is seen around the equators. The darker skin type can be found mostly between 20° north and south of the equator. In the extreme poles, the skin color is changing. And the study is already done, and there is a population race. It is determined that by 2040, the population of skin of color will be increased or overpass the people of white. So this consequence is getting bad day by day. So our topic is usually mainly for the psoriasis patient. So what ethnicity does psoriasis affect? Still the study we relate white people are more affected than Afro-Caribbean and Hispanic population. And the disease burden is also observed in white population than Latino patient. But you can see the changes of different color type. Fitzpatrick classification 2, 1, 2. You can see the red background with silvery scales. Gradually it is changing to Hispanic. It is type 3, type 4. The color is salmon color with thick whitish scale. Gradually it is coming to violaceous background with grayish scale, and ultimately you can see the skin color is changing, plaque is changing to violaceous base with thick blackish or grayish plaques. So these are the changes we can observe in the skin of color. About the severity, we have seen that the Asian people and the Hispanic patient, the severity of psoriasis is more, according to a study, rather than white people. Then what will be the pitfalls now? We have to discuss it now. About the diagnosis and the differences of the phenotypes of psoriasis. This variation can sometimes pose challenges in accurately identifying and managing the condition. So number one, we can discuss, that is the underdiagnosis. The psoriasis may be underdiagnosed in individual with darker skin tone due to the misconception that is primarily affect the individual with lighter skin. The healthcare professional may be less familiar with the diverse clinical presentation of the psoriasis in skin of color, leading to missed or delayed diagnosis. Doctors usually in the white population, they have received inadequate dermatological education, especially on the skin or color. And there is a limited clinical training and reference material available to dermatological resident. Number two, we can say atypical morphology is there. The characteristic silvery scale may be less prominent or absent, and the lesion may be darker or more pigmented. The atypical morphology can make it difficult to recognize psoriasis and differentiate it from other skin condition. We can see this picture, the white skin, dark background with reddish background with silvery scale plaques, whereas in the dark skin you can see the violaceous border with thick gray to black and whitish scales. So there are some atypical type of psoriasis, that is rheumatoid psoriasis. It is very difficult to confuse it with other condition of skin. It is cone-shaped type of lesions. And another one is osteitis psoriasis. That is also a plaque type of psoriasis. And it can be confused with other lesions of other types of skin lesions. So the diagnostic confusion is there, especially with the lichen planus, discoid lupus erythematosus, seborrheic dermatitis, or even fungal infection. This acanthosis nigricans, the thick velvety plaque, can be confused with psoriasis. The lupus can be confused. The seborrheic dermatitis, the plaques can be confused with the plaque type of psoriasis. Even the fungal infection, tinea capitis, sometimes confused with psoriasis. So there are other factors also. The eczema can be confused. Cutaneous T-cell lymphoma can be confused with different type of other skin lesion. So there is a diagnostic challenges. The people of color are 4 times more likely to require a skin biopsy or dermoscopy to diagnose the disease and wait 3 times longer for a definite diagnosis compared to white people. This lesion you can see, the lesion is not well bordered, but it looks like eczema. When we do this dermoscopy, there is a features of psoriasis. Another lesion, it looks like a contact dermatitis, but when we do the dermoscopy, it has the features of psoriasis. So even this one, hyperkeratotic lesion, if we see, this thing can be confused with lichen planus, hypertrophic lichen planus, and when we do the dermoscopy, there is the features of psoriasis. So there are different confusion is there definitely with the diagnosis. Hübner's phenomena, everybody we know. In individual with skin of color, post-inflammatory hyperpigmentation is common response to injury, and the psoriatic lesion may be mistaken for post-inflammatory hyperpigmentation. This results in a mixed diagnosis or inappropriate treatment. The variation in distribution, usually in skin of color, we can see that the face, flexure areas, and scalps are mainly involved. But in other white population, the other part usually involved. It has been seen that Asian and black people, scalp psoriasis is common. Culture factor is also there. Culture practice and preferred, such as the use of skin lightening cream, may alter the appearance of psoriasis lesion or affect the patient's willingness to seek medical attention. These factors can contribute to delayed diagnosis or reluctance to disclose symptoms during medical consultation. You can see when the lesion hyperpigmentation is removed, the patient doesn't want to go to the doctor and the delayed diagnosis is there. The post-inflammatory hyperpigmentation, after the resolution of the psoriasis lesion, individual with skin of color may experience post-inflammatory hyperpigmentation. This condition causes area of the skin to become darker and surrounding, and that can be complicate evolution of the disease activity and response to treatment. So you can see the plaque of psoriasis, when treated, there becomes a hyperpigmentation, and it is confused sometimes what is the actually what this hyperpigmentation is. So phenotypic racial differences in presentation, as a gross we can say that the plaque psoriasis is common type of psoriasis among all races. Pustular psoriasis is more likely to seen in Asian and Hispanic population. Asian population are more likely to present with erythrodermic psoriasis and less likely to have inverse psoriasis. One study found that Asian and Hispanic population are more likely to present greater disease severity than Caucasian population. East Asian patient have smaller, less widespread plaque than Caucasian. And Asian and black patient are also more likely to present with scalp psoriasis. These are the findings from a study. So is psoriasis more severe in black people? Definitely yes. The black people, their psoriasis is white body surface area is more than the white population. What about the Indian scenario? There are some study I found, and there is a common types. They have the plaque type, palmoplantar types, and the distribution is usually the scalp, trunk, limb. And the uncommon variety, they have inverse, gutted, erythroderma, and pustular psoriasis. What about the oriental skin? In study in China, they have shown that majority of the patient are psoriasis vulgaris. 1.56% were pustular psoriasis, and 0.7% is erythrodermic psoriasis. So features of dark skin, what will be like that? This is a plaque psoriasis. You can see the thick patch of skin, that purple to gray with scales. Gutted psoriasis, you can find the small pinhead, small bump with flaky grayish scales. And the inverse psoriasis, it will look like a patch of moist, smooth, shiny skin. Palmoplantar, you can find there is a discolored, dry, thick skin on the palm and sole. And in erythrodermic psoriasis, you can find the skin, the redness is there in acute case, but when the case resolves, there is a grayish scale all over the body. So pustular psoriasis, even that, the redness is there, but the redness is not like the white population, it is a bit dark. And after a few days, the pustules appear, and ultimately it resolves into the change of hyperpigmentary changes are there. So the take-home message, the skin of color patient are projected to comprise the majority of the population by 2044. Yet knowledge gap in the clinical presentation and treatment of both common and uncommon dermatological condition in skin of color persist. To overcome these pitfalls and address the difference in phenotypes, dermatologists and healthcare professionals should receive education, training regarding the diverse presentation of psoriasis in individuals of skin of color. Increase awareness, improve diagnostic criteria, and personalized treatment approach can help ensure the accurate diagnosis and effective management of psoriasis in patients regardless of the skin of color. Thank you very much.